Good morning. My name is Conway Pebley, and today we're going with Caleb Lowe, and we're going to be going over spinal precautions. I decided to choose spinal precautions because of the amount of sand accidents that we have here on the coast, the amount of MVAs that we have, and also just have a high number of geriatric patients that occasionally need their spine immobilized in some way, shape, or form. And so just getting a better understanding of why we do it, when we shouldn't do it, the benefits and um, damages that we could possibly cause is why I chose this.
Hello, my name is Caleb Lowe. I'm Conway's partner in this presentation. To build off of what Conway is saying, as much as I agree with his, I also chose to do this because I have seen that EMS is slowly taking away the implementation of the KED and the short backboard, and for many reasons and studies that have been proven on that, I wanted to look into long backboards and the spinal precautions that we use outside of KED and see if those are ethical and effective as well.
So what we're going to go over today is the efficacy and current spinal precautions, some of the techniques that we can use for better patient outcomes, and how we're going to get there is by just quickly covering a history of backboarding, go over the intent and purpose of spinal precautions. We'll review some patient statistics and go over some techniques and tools that may replace the backboard or the long backboard. So with the motor vehicle accident fatalities at an all-time high in the early or in the 60s and early 70s, these really highlighted the need for spinal precautions. In 1971, the American Academy of Orthopedic Surgeons published The Emergency Care and Transportation of the Sick and Injured. It's the book that we use still today. I mean, it's been updated, but it's our EMT book. And this book, in it, it has instructions for the use of spinal immobilization using the backboard and C-collar for trauma patients that have the signs and symptoms of a spinal injury. And because the fear is that rescuers are going to inadvertently worsen an unstable spinal injury during an extrication and transport, which is what led to the adoption of field spinal immobilization protocols using C-collars and backboards only indicated based on the signs and symptoms. But in 1979, Dr. Bowman, he's an orthopedic surgeon in Cleveland, Ohio, he published an article about the delayed paralysis in about 1/3 of his C-spine fracture patients, which were attributed to spinal cord tissue hypoxia due to cord compression from edema, contusion, or direct injury to the cord's vascular supply. His concerns when he wrote the article were that he had a theory that the emergency room physicians were just underappreciating the causative nature of the injury, and patients were spending too much time on their backboard or in their cervical collars, and that's what was causing these injuries. So not only were the emergency room physicians getting the finger pointed at them, now then EMS providers were also being blamed for delayed paralysis and improper packaging in the field. And from this fear, EMS began applying spinal precautions based on the mechanism of injury alone. So even if the patient was asymptomatic, responders were trained to use the spinal immobilization techniques as we know them today, taking manual C-spine till C-collar is applied, maintaining full spinal precautions throughout the entire extrication, and maintaining complete immobilization with a C-collar and backboard until the patient's been cleared from a doctor. Kind of a little bit of the intent and purpose of the backboard. So how is it intended to be used to protect spinal damage? First, there's no conclusive in-depth scientific studies that confirm that a damaged spinal column was not made worse due to the use of a rigid backboard. These are hard studies to academically reproduce because of ethics. We can't transport the same patient twice that may or may not, that has a spinal injury. One time we'll do spinal precautions and then transport them right afterwards without spinal precautions and see which way is safer. That kind of goes against the whole do no harm. because we're trying to see if one works or doesn't. But the intention of the backboard is to provide rigid support and spinal mobilization for extrication and transport. The idea is that if the person can't move, neither can their spine. Still, spinal precautions need to be taken, even if using methods other than the long backboard. And indications for the spinal mobilization include somebody with altered mental state or altered level of consciousness, their midline spinal tenderness or pain, some anatomical deformities of the spine, CMS or neurological complaints, weakness or numbness in their extremities, the mechanism of injury with distracting injuries, signs of intoxicant or language barriers with the distracting injuries, and some of the contraindications would include trauma to the head, neck, or torso. And then log rolling the patient. Some studies show that there's significant lateral motion control being lost when a patient's log rolled. And the purpose of the log roll is for us to be able to assess the back for bleeding and penetrating wounds and to check the spine for abnormalities. It is a convenience since it's a move that requires the least amount of people to perform, but you do lose the stability and immobilization factors of your thoracic and lumbar regions.
So, as Conway briefly touched on in a couple slides ago, we are not here to argue that nobody should be long backboarded. We are here to say that there are problems and difficulties that arise due to backboarding, and we just think that there should be a higher level of assessment prior to choosing full spinal precautions. Some of these difficulties or problems that can arise, the main one is discomfort and agitation. Laying on that hard, rigid backboard while strapped down can be very uncomfortable. This can actually cause pressure sores, which can arise from anywhere on the back of the shoulders down to the buttocks region, kind of any main portions that will make hard contact with that hard backboard. Due to this discomfort and agitation, it can actually cause the patient to try to readjust themselves to become comfortable, which then raises a huge risk of, if there is an injury that they are now trying to fight against the backboard, it can cause further injury. Another fairly big difficulty / problem that arises from full spinal precautions in backboarding is that with all the straps, that can cause some extra pressure on the thoracic area, which can make respirations about 15% more difficult, whether this is the patient breathing on their own or a provider giving rescue breaths, as well as once we have a patient in a C-collar, it reduces the range of motion of the jaw by 25%, which can make it much more difficult to control that airway if something were to happen, if you needed to enter an air junt, or if you need to suction or intubate for any reason. Some of the studies that have looked into full spinal precautions there are two of them that we found, one of the main ones being a retroactive comparison study of a hospital in Malaysia versus a hospital here in the States in New Mexico. The hospital in New Mexico had roughly the same amount of transports as Malaysia, and they were doing full spinal precautions. They were using the method that is common in the United States for EMS, is that they were basing it off of mechanism of injury versus actual assessment of the patient. This is compared to these patients in Malaysia, where they were not doing any spinal precautions. Once they got the results from these patients, they actually took all these results to two separate physicians, and it was a double-blind scenario where the physician didn't know which patient they were getting, and the studiers didn't know which patient they were giving to the doctor, and checking out the results of the mechanism of injury versus the actual injury that was sustained themselves. And in the New Mexico study, it was found that about 21% of the patients walked away with some kind of deficit, whereas in Malaysia, it was down to only about 11%. Now, they did not go as far to say that last 10% was because of spinal precautions. This is just to discuss the efficacy and the effectiveness of these spinal precautions with that 10% difference. In another study done in 1998, there was a comparison from the spinal board and the gurney mattress. So they had volunteers line up and they were either strapped to a full C-spine board, or they were laid down on the gurney mattress and placed 3 calibrated discs, one on their head, one on their chest, and one on their hips to show any lateral movement. And then the driver of the ambulance was told to take the same course at roughly the same speed, about 20 miles per hour, and see which was more effective at keeping the patient in place. And in almost all fields for head, chest, and hip movement, the results were half that from the gurney mattress compared to a long spine board, which means that not only is it more comfortable for the patient, but it's more effective on actually holding them in line when you are moving the patient. Some of the methods that we suggest that we should use in EMS instead of the log roll and hard backboard, some of the main ones would be scoop stretchers. This allows us to pick up the patient without having to move them laterally at all. And the good thing about a scoop stretcher is you can use it to get the patient off of the ground or out of whatever position they are in and onto now either your vacuum bed or your gurney bed, which is proven to be more effective and more comfortable. And you can actually take that scoop stretcher out from underneath them. So now the patient has had no lateral movements and they are in a more effective and more comfortable way to actually be transported to the hospital. And I think that these are great ways that are very underutilized in the field. I do believe that there still is a time and place for full C-spine precautions. I just think that we need to be looking more into the patient's current status before we decide what to do. So in conclusion, we wanted to look over the effectiveness and the efficacy of full spinal precautions. We believe that they're partially overused and can actually be harmful to the patient when they are overused. Again, they can cause pressure sores and discomfort, and then they can actually make controlling the respirations in the airway a little bit more difficult. I think the number one thing that EMS needs to be doing is we need to be giving a higher level of assessment prior to choosing full spinal precautions. We need to make sure that this method effectively fits this patient. If it doesn't, then we should be using either the stretcher mattress or the scoop stretcher to be able to get them from point A to point B and then make sure that they're comfortable but secure.